this little button called record this meeting. Let me get this out of the way. And again, it is with great pleasure that I introduce Liza Behrens, who comes to us from Penn State University. She and I have only recently met by phone, but when she told me her work is on person-centered care, I was very excited. As I announced in the faculty meeting the other day, this is one of the important buzzwords that is going around in policy conversations and hospital conversations. How do we make our care more person-centered? It's also going to start to connect to payment, and it doesn't connect to payment right now, but because we're a policy-focused kind of program, we have to keep our eye on how all of these sorts of new definitions and new things begin to connect to the economics of policy of person-centered care. So I thought it was really important to bring Liza to campus, and let me put her up so I can turn the microphone over to her. I have you down in the middle. That's fine. And I'm going to do that. And you will see, move you out of the way, but you'll know you're on. Okay, everyone, bear with us, but join me in welcoming Liza Behrens. All right. Clicker, you know well enough. You can be in there. You can up and down arrows.
All right, thank you.
You're very welcome.
Nice introduction.
You're very welcome.
Hi, everybody.
Hello.
Thank you for having me here today. If you guys don't mind, before I get into who I am, because the first few slides are about me, Dr. Fig asked me to talk about my journey a little bit, so I'm going to do that. So I'd first like to get to know you, though, a little bit. So I'm hoping we can go around here and then on the phone and just say, who you are, what your interests are, and where you're at, if you're a faculty or a student. Maybe we can start over here.
My name is Geriatric, and I'm a full-time faculty here. I teach biostatistics or critical care. One is DMT student, the other is for the undergrads. My research interest is all over the place. I just finished a couple papers on teaching biostatistics and some benchmark data on biostatistics teaching. Now I'm probably going to move on to do a little bit simulation thing and go back to the large data.
I talked about that earlier. I'm sorry, what did you say your first name?
Aaliyah.
Aaliyah. Nice to meet you.
Hi, my name is Francine Bononieri. I am an adjunct faculty member here as well as a PhD student. I am clearly pediatric based, as all of you know that know me, but my interest is really in simulation and trying to bridge the gap of the dichotomy that exists between nursing school and actually coming to fruition as an RN, and what we can do to bridge that gap to prevent errors of omission.
Great.
Thank you.
Nice to meet you.
My name is Camille Charles. I'm a PhD student here working on my dissertation. I'm a nurse practitioner also, and I teach adjunct. My interest is actually cultural related, and I'm looking at West Indies women with hypertension and their focus on their health locus of control.
Thank you.
My name is Marcia Kate, and I teach in the undergraduate and graduate program here.
Great. Nice to have you. Any particular student, med-surg?
Med-surg.
Great. Nice to meet you.
I'm Teresa Rienzo. I'm the Health and Life Sciences librarian, and I help most of the individuals in this room with their research and their students. So I like to know what's going on, so when I see new things come out or are on those topics, then I can refer them to the correct people.
Awesome. Nice to meet you.
Hi, I'm Marcia Williams-Haley. I completed my PhD program here, recently switched from adjunct faculty to full-time faculty. I'm a nurse practitioner also in psychiatry, and so my specialty is with the psychiatric population with a focus with metabolic syndrome.
Nice to meet you. We might have some similarities.
Yes, right.
Congratulations, by the way.
Thank you.
I'm Jennifer Withall. I'm a PhD student here. Just in my last full semester of coursework. So now the big question is, what are we doing? So I like everything, which is a little, but older adults generally, and I really enjoy working with data.
Sit next to the right person for that.
That's right.
So Liza and I know each other, and I think all of you know me, Patty Eckhart, quantitative methods, and then also clinical research nursing is my other area of interest for research, and that's where Liza and I work together.
Great mentor.
Hi, I'm Rebecca Rosick. I'm full-time faculty here, and I teach kind of across. I teach undergraduate, graduate, and doctoral. Undergraduate is obstetrics and pediatrics. That's my whole background in spoken PACE, and complete opposite end of this. So, and my research has been some with students, some with family-centered care, and some with lactation research.
And just to let you know, too, Anne Marie and I are accepted for a symposium at the Sigma conference in Dublin on family-centered care, and we're probably going to be debating with people who are person-centered care or child-focused care or child and family-focused care, and so that you know that the landscape isn't only person-centered care, but Anne Marie and I are going to try and find our way internationally with what other folks are doing, and also the Brits. The people who have public financing are certainly interested in this. So that's kind of, I know that, but
that's a great
just Anne Marie and I are buds in that endeavor.
Congratulations with that too, going to Sigma Theta, and I'd be very interested too, if you guys are interested early on, practicing some of those debates. I know that some of the faculty that I work with at Penn State are very passionate about it. So it might
Thank
be a
you.
nice
That'd be
way
great.
to
That'd be great.
Sort of
That'd be
practice
great.
the debate and the international landscape, because it is different.
That'd be great.
For sure. Nice to meet you.
I'm Laura Schechter. I'm the Associate Dean of the Undergraduate Nursing Program, and my research interests focus on academic integrity and professional socialization.
Nice to meet you.
Hi, I'm Maureen Mulder, and I'm nursing also, and I teach from freshman studies on up to the doctoral program. And as exhausting as that sounds, I love it. I love it. It took me a while to figure out why I was so tired, but it's really a challenge. And originally, my research was focused around culture and culture care, and I'm tending to get away from that right now, so I'm exploring.
Well, my name is Rosemarie DeLuca. I'm a friend and colleague of Liza's. We work together in clinical research, where I still work, and I'm here for support.
Support and a little bit of encouragement.
Support and encouragement.
Everyone knows. Everybody knows me.
So we go on to the phone. Anybody at distance want to introduce themselves and tell us a little bit about yourself?
No, they're not muted. They just have to step to the plate. Hello.
Anybody want to be brave?
Sometimes I have to mute people because the dog's barking in the background.
I can't tell if they're muted.
That little double arrow right there. Not that one next to it. Yeah, open that. That'll see.
Kids at work.
Hello? Yeah, who's that?
Can you hear me?
Hi. Yeah, this is Giselle.
Hi, Giselle.
Okay, hi. No.
Yeah, I'm applying to Molloy for this fall coming up, so hopefully I'll be a PhD student in the fall time. And I work at Stony Brook, and I'm at work right now, so I'm taking this from there. And I'm just excited to be a part of this and listen to this, what sounds going to be a great talk. And my interest and my background is in maternal child health, so I'm really interested in group-based prenatal care.
Great. Nice to meet you. Thank you for coming on.
No problem.
I think I also see a Heather Reams. Heather, are you there?
She has a baby.
She may be muted because.
Okay. How about Julie? We have a Maureen.
Maureen is at work. I don't know if she's.
They might not be able to talk either. Okay, move on.
Thank you.
Thank you.
Well, thank you everybody for doing that. That really helps me. It's something that I enjoy doing, getting to know everybody. So I thought I would
Click that, not the X, right there.
All right.
Get it out of the way. All right.
So as Dr. Feig mentioned, my name is Liza Behrens. I wear many hats. It sounds like that you all do the same, so I'm in good company. And I wanted to talk to you today a little bit about building a career as a nurse scientist, or my journey to do that, and then also about a project that I've been involved with in defining person-centered care in the long-term care environment for the reasons that Dr. Key was just mentioning. So without further ado, like any good nurse scientist, I'm sharing my worldview. I'm going to move this just so I can see straight out of the way. There we go. Okay. So my worldview coming into research, and this is something that I think as a doctoral student, for sure, I had to really reflect on, and has really driven and guided how I think about the area that I'm going into. And how I think about people, I think about humans as people, right, that are self-organizing and that we're goal-directed and that we're really living systems that interact with our environment. And we do this, with our mind, with our bodies, but also with our spirit. And that really promotes a level of homeostasis, a level of well-being. And this is very important to me. And I think you have to have all three in check to really thrive and do well. I also firmly believe that we have social responsibility, as I'm sure all of you do as nurses. But I've always clung to do unto others as you'd have them do unto you. I mean, it's that golden rule, and I really firmly feel that that's driven a lot of the decisions that I make in daily life, but also in my academic and professional career. And then I firmly feel, we need purpose, and that God put me on this planet to care and advocate for people who are without the physical, cognitive, or spiritual resources to do it for themselves. So that's how I come into my research and academic career. I'm sure I share that similarly with some of you. Articulating it is the challenge, right? So I put this up here because, when I was trying to think of what does a career path look like for a nurse scientist, I struggled with this a little bit, and I still continue to struggle with it daily. My goal is to, being the goal-oriented person that I am, is to be a clinical nurse scientist. And so I had to sort of say, well, how do I get there? What's the path? And the path, typically, as I've found, and many of you could probably agree with me, is that you have to be a nurse, and then you get a bachelor's in nursing and a master's in nursing, and you go do a pre-doc, and then you go do a post-doc, and then you're tenure-line faculty. Well, what does that mean? And for me, it was missing some of those other contextual pieces. So I've been told several times, and you can secretly raise your hand if you've been told this by anyone in the past, you just have to do it, and you have to focus, and you got to get it done, and you have to put everything else aside. I just don't believe that we can do that. We're people. We're human, right? We're self-organizing. We're goal-directed, and we have needs. And so I think we have needs as students, as professionals, as nurses, as people, and we're trying to also meet the needs of our clients. So I'm going to show you what my path has looked like. And I wanted to show you this. So how many of you have seen the 21st century, the new NINR strategic plan? Anybody? No. I have to bring that class. So obviously I always recommend you look at this, and anytime it's updated. But what piqued my interest in this strategic plan was this section that's been added on to the 4 areas of research that NINR is supporting, is that that they've added this idea of supporting innovation, and then also of supporting the 21st century nurse scientist. And it was quite interesting how it was described here, and I'll just point this out. A statement in here that says, it's essential that the scientific workforce of the future be innovative, multidisciplinary, and diverse. NINR supports a wide range of activities in both its extramural and intramural programs to ensure excellence in the next generation of nurse scientists. In addressing the goal of preparing a diverse and talented research workforce, NINR supports a variety of training opportunities for scientists and trainees at all career levels, particularly those in an early career stage who are so critical to sustaining the future of innovation innovative research and high-quality healthcare. Let me read that again, just so you all hear it that are at least in doctoral programs. We are essentially critical to sustaining the future of nursing research. We really are. There are not many nurse scientists out there. But where I will argue against is that we have the resources we need as a 21st century nurse scientist. So hopefully we can advocate for ourselves in the future on talking about the types of resources we might need. So this is my career trajectory so far. It's a little busy, but I think that's I know it's very purposeful. So I hope to just take a quick second so that I can take you down my path. And it may be very similar to you. So originally I wanted to talk to you about my career path from being a clinical research nurse to where I am today in a doctoral program, also working.
Liza, I'm going to interrupt just for a second. Sure. Someone's got some background noise on, and I said I was going to be muting it.
This one.
It isn't?
I think it's the gentleman. Let me go and see.
Okay. Oh, thank you, Rose. I appreciate that. Sorry for interrupting. I just thought that I was going to, thank you very much. This is great. Sorry, Liza. I just want you to have full attention.
But I wanted to just pause for a moment. How many of you worked prior to your nursing career? How many brought experience before you became a registered nurse? And what kinds of things did you do?
I was a nursing attendant. I was involved in business with my husband, financial level. I did a lot of other things besides nursing, but my focus was always nursing.
Anybody else want to share what they did before then?
I worked for the New York Telephone Company back in the day.
Great. Communication. You must have been good at communication. That's great. And has that colored how you've looked at your nursing career?
I think so.
Well, yes, it is definitely part of my biography. And that's been true for me. I'm very much interested in the health and well-being of older adults. I think part of that is certainly from my values that I just shared with you. But as I reflected, I was like, why older adults? Like, why did I pick older adults? What? So I had to choose a population was my first response to that. But then I really reflected, and I have interacted with older adults who've had cognitive disabilities since before I even became a nurse. And I think this really has colored why I am so passionate about the geriatric population. So this first guy here, and oddly enough, this picture, which is web-based, looks a lot like Mr. Graziano. So when I was in nursing school, which, by the way, I got rejected from the LPN program and had to take an ADN program. I just but Mr. Graziano was a gentleman who had Parkinsonian dementia, and he was in the state hospital in Vermont, and he was in there because the nursing homes couldn't handle him. He was an old railroad worker. He loved to dance. His wife was very doting, but he was very strong. And the staff in the nursing homes were not able to take care of him because he literally could pick you up and move you. And when he would have mood swings, you would see that. I fell in love with Mr. Graziano, probably because he would dance with me, and he literally would pick me up and move me. And I didn't understand the significance of that when I first encountered Mr. Graziano, but years later, I'm so grateful to have had that experience with him, but also to have the experience of trying to take care of someone who has a cognitive illness and who really needed support. So that was just before I finished my associate's degree in nursing, and I went into nursing saying, I'm going to med school, so I'm just going to get this LPN, ADN, whatever I'm going to do done because I'm going back to med school. And so I started nursing in 1999 in a psych floor in a hospital. Psychiatry is clearly my love. Started as a staff nurse. Got a bachelor's of science in biology, thinking med school, right? That was in 2001. Well, then once you're a nurse, I think nursing chooses you. So you're all right. And then I was a staff nurse for quite some time, and I enjoyed that. I enjoyed going through the levels. I enjoyed doing the critical care. I enjoyed interacting with my patients. But I started to feel a little hole in my heart. And I don't have a better way to explain that. And what that was related to is this woman here, and we'll call her Grace. because honest to goodness, I can't remember what her name was, but I'll tell you, I'll never forget this patient. Grace was around 65, maybe 67 years old. She was a patient of mine on the medical intensive care unit that I worked on, and she had come in, actually it was a coronary care unit that turned into a medical ICU. And what happened is she was having cardiac arrhythmias because she had breast cancer, and it was reoccurring breast cancer, and she had been in for chemo earlier that day, and she was so dehydrated that she just kept having arrhythmias. So she came in initially to be monitored. I will tell you that Grace left a huge impact on my nursing career, because by the time we were done, I think we coded Grace 2 or 3 times. She had a tube in every orifice, and I'm not kidding. She was on a balloon pump to support her heart. She was had central lines everywhere. She had bedside dialysis, and her daughter was just clinging to hope that this lady was coming back. And from previous conversations with Grace before we even went this far, she said, you know, I don't want to suffer. And all I could see in poor Grace was suffering. And you could tell she clung for her daughter, but her daughter was not coping at all. There was no communication around it, and it was very difficult to get anyone involved. Pastoral care, ethics, it just was the time. So Grace, to me, was really that opening eye that I need to do something. I need to go back to my roots. I need to do something other than staff nursing, because it wasn't aligning with my values and what was important to me. So I decided to go into research, right? I did undergrad. I can do it. I can do this. So I became a research coordinator, and thought, I'm going to have more time with my patients. I'm going to be able to do some research, and I'm going to go back to school for nursing, because I think I want to be an advanced practice nurse. So this picture right here is Bubby. And Bubby is my husband's grandmother. He was 93 at the time of this picture, and that's my first son, Keegan. And why this is so important is because Bubby was a huge supporter of, obviously, our family, a matriarch for sure. But the importance that I want to share with you is that Bubby suffered from osteoarthritis, certainly osteoporosis. She had always been an energetic, traveling type of person, and just at the end of her life was chair-bound. You want to know why she was chair-bound? Because she was on rofecoxib, and they took it off the market. They took it off the market because you guys all remember the huge problem we had with that drug, that it was causing GI bleeds, serious GI bleeds. Well, for Bubby, it made her walk, but for other people, it made them bleed. And Bubby said, I don't care if I bleed. I'm 93 years old. This drug makes me walk. And after that, she gave up. She was done, and she died because she did not want to be chair-bound, because a drug that she could have had was taken off the market because of side effects. And so that was really eye-opening for me as I was going into the world of clinical trials research, testing new drugs and devices. And I said, this isn't right? This isn't right. Why is it coming off the market? This is helping people. And part of that is because I knew, or began to learn, that drugs weren't tested in this population. Typically, anyone over 65 were excluded from clinical trials. So the drugs that we were giving weren't even tested in this population, nor were, the side effects collected, obviously. And so that was a real eye-opener for me as well. That, and one other key thing that I hope you'll hear, and you'll appreciate this one. I was mortified to learn that in a pharmaceutical clinical trial, someone, a pharmaceutical company will come into a clinic and say to a physician, here, I want you to do this trial, consent your patients, have them take this drug for a while, just give us information. And that's pretty much what they had done in those days. And I had gone to what they call an investigator meeting for a new drug, and I met a secretary. And she's like, yeah, I run this study for my physician. I keep the drugs in my office drawer right next to me so I can just hand them out. There's no, education, no administration, training, nothing, nothing about collecting side effects, nothing. She was handing out, and mind you, this was a cardiac drug. She was handing out a cardiac drug that was investigational. Yes, it was a cardiac drug. And so I said, really? You can do this? She's like, yeah, there's nothing in the laws that say I can't. You know what? That's still the case today. Still the case today. Anybody can deliver an investigational product to a patient. And that includes your patients that you're taking care of right now who may be in the hospital. So the only thing that may influence that is your hospital policies or your clinic policies. So that really set me off. So that's when I became certified and got involved and said, there's got to be something else I can do. And I think this is my policy hat, where I said, okay, what can I do as a nurse? Because this organization where I became certified through is really for all clinical research professionals, and the person who could be certified to take care of research participants are high school diploma folks with 2 years of experience. It sounds like you might have experience with this. So I said, there's got to be something that's nursing specific. It really isn't. I mean, the Oncology Nursing Society has a good path. They don't have a certification yet. So that's how I got introduced to two things. One, the Master of the Science program in Clinical Research Administration, which I knew immediately was for me, and two, to the International Association for Clinical Research Nurses, which was started in 2009, which I was very grateful to be an inaugural member of that organization. And that has colored a lot of my professional journey. A lot of people I've met, like Patty, because of being involved in an organization. So immediately, as I do, I jumped in, head, feet, hands, and I said, what can I do? Well, all right, you guys know how this works. You say, what can I do? And you get lots of stuff. So I did end up, working with the education committee early on, and then became elected as the president-elect, and then served as the president for 2 years. And now I'm the immediate past president. But I'll tell you what, this journey has been incredible. And it's something that I'm very, very passionate about, which you'll see. But that really has sort of helped me think about my path and where I'm going. At the same time, I thought, well, I'm a nurse, and I should be doing nursing research. So I spent the last 10 years at Geisinger Health Systems. I don't know if any of you are familiar with that group. What's beautiful about that health services organization, really is what it is that we do have a few nurse scientists on staff. And I began working with a nurse mentor who really supported my curiosity and my determination to do something about the lack of support for really nurses who are taking care of research participants, but on the end, who's taking care of the research participant? And how passionate I became in saying, okay, there's a person at the other end, and if someone who's administering drugs doesn't know how to do it and messes up, who pays the consequence? The patient. So she helped me sort of get engaged into and actually helped me create a position as Associate Director of Nursing Research for Geisinger Wyoming Valley, which is where Rose and I had connected. This was, again, an amazing experience that has influenced my interests to today. And I got involved in nursing things because nursing was completely separate from the clinical trials office where I worked. And it still is, we struggle with this, still is today. Nurses who work in clinical trials are often separated from the nursing. So I worked very passionately and purposefully took this position and created this position as Associate Director of Nursing Research so that I could start marrying the two. And that's where I got involved in niche. Does anybody know about niche? Nurses, let's see, it's nurses in, I'm going to get it wrong, but basically it's Nurses in Care of Hospitalized Elders program. And it really teaches you how you can be mindful about the older adults, so those 65 and older in your healthcare system, and what kinds of things that you can do. And that started out of NYU, by the way, so you guys are very close to that. And we have Dr. Marie Boltz at Penn State now, who worked on this program too with Dr. Capizzuti and others. Anyway, so I'm digressing, but this was at the same time I was still thinking, what am I going to do for my dissertation? What really interests me? And so that's when I got into the gero nursing world over here and said, okay, what can I do? And I met Dr. Ann Kolanowski, who you'll see there, and she's holding up a book called Carol's Journey. And Carol's Journey is a book that was written by the dean, actually, Dean Ford, who ran the Health and Human Development,
College of Health and Human Development.
Thank you, at Penn State.
That I graduated from.
And he actually
had to throw one in there.
He was the first dean of the nursing school at Penn State. And years later, I've been able to get to know him, and he's fabulous. And he, too, looks at people as self-directed, goal-oriented individuals. So we have some wonderful conversations. He's a psychologist. And so that's really helpful, too, for me, because he counsels me. And I think he loves to do that. But anyway, so the story is about him taking care of his wife at home with Alzheimer's disease and what he needed to do. And it's amazing. I hope we all can have a Dr. Ford as a husband because, or as a spouse, because I'll tell you what, the things that he did for his wife helped her live longer with Alzheimer's disease and helped her be happier. And he figured out things about her and her personality that he could tap into, that once he tapped into them, he really could help her thrive and have a better experience, even though she couldn't remember things. So, for example, he tells a story all the time about how much she used to love to play piano, and it became more difficult for her. And he said, well, every day they would have a session where he would turn on her favorite songs, put a record on, and they would dance in their living room every day. And he said, he will tell the story. He said, you know what, dancing with her like that was like she never had Alzheimer's disease. It was like they always used to dance. So there's something there. And I'm so driven to sort of help figure out what that is for these other people, like Mr. Graziano, right? So Anne introduced me to that. And she really introduced me to the research that she's doing in long-term care. And she really introduced me into, nursing science, and that you can make a career out of nursing science. So I'm grateful to that. And so I work with Dr. Kolanowski now, and she predominantly works in long-term care. So that's sort of up to the last few years where she said, well, Liza, have you ever thought about getting your PhD at Penn State? Well, maybe. I work full-time as the director of an office. I don't know if I can do that. But I took the leap, and I started Penn State in 2013 part-time, and then went full-time the last couple of years. And that's really where I've made, I think, the most progress in terms of my career development. And it's also been probably the years of the most stress. And I think some of you may be able to relate to that. I was very fortunate to have opportunities to, be active in my professional organizations, serving as president of an organization, international organization that's growing, grassroots growing, starting a chapter for research professionals that were non-nurses, local to our group. And then also, trying to grow my own academic knowledge. I became a fellow of the Rock Ethics Institute, which is the ethics institute at Penn State. I went and taught in China, clinical research nurse training, and really promote, try to keep our board of ICER moving. Quit my job, went to work. You guys know this story, I'm sure. I'm sure you know this story. And so I think that's what led to some really wonderful things, and one of them is a project that I'm going to share with you in a moment. But I really want to highlight to you that although this seems like a lot, and although you may be in a place where some days you don't know whether or not you want to keep going, I just keep going, and I keep going because of the things that happen. So, for example, I've had the opportunity, because I've been the president of an organization, to contribute to the Oncology Nursing Societies, Oncology Nurse Competencies, Oncology Clinical Trials Nurse Competencies. And that's something that's driving education and training of nurses who are taking care of research participants, and that was my passion, right, to improve the lives of people at the other end. And this past year, we finally released a Scopes and Standards of Practice, and we're recognized by the American Nurses Association as being a practice in nursing. To be a clinical research nurse, which is different than being a nurse scientist. We clearly recommend, clearly are distinct about that, but I think that brought a lot of validity to what's been, what nurses like us have been doing for a very long time, that it's a practice and that we have special skills and knowledge. And then very excitingly, we were able to start a foundation, and I've been able to, now I'm secretary of the foundation for Friends of International Research Nursing. So I've been able to keep that part of me that I really love, and now I just want to figure out how to marry the two, right? How do I marry my passion for clinical research nursing and research participants and what I do as a nurse scientist? And I think I will be successful with that, and I hope to finish my PhD in the next couple of years here. So any questions about this long path? And I'm sorry.
Let me see a show of hands and relatable.
Yeah. And I don't know what's going to happen after 2019. I think who knows? I guess it depends on where I'll be.
One addendum though.
Yes, you may.
Liza is also driving the good clinical practice competencies that are nurse specific, that aren't out there yet nationally or internationally. She's the backbone of that for our organization.
Thank you. It takes another person to do the praise, not to praise oneself. Thank you, Pat.
I was happy I got this on here, but thank you, Pat. This is really hard. But I really I think nurses are often left out of that conversation, and that's why we need to be there. For our patients, for those people we want to advocate for, and I think that's what gets me up every day. And I think the fact that this program that you're in here has a strong policy component, you have people who can connect you to those, that's amazing. You have a gift, because not all programs will support that kind of work at the same time. So keep going. Just keep getting up in the morning. All right. So that's where I want to take you into, my goal of marrying my love and passion for developing, clinical research nurses, and also promoting the health and well-being of older adults. Okay, so I finished my coursework. Who just finished their coursework? Who was it?
Jen. Oh, well, I'm on the tail end of things.
Jen. So I'm on the tail end. I have my dissertation seminar left. So I have to figure out what I'm going to do, right? And I've been fortunate. I'll share some projects that I've done. But I just wanted to center myself back and say, well, what is it? Again, I'm caring for older adults that I really love, and older adults who aren't able to advocate for themselves. I really feel like I was put here to love them, especially when they don't have that for themselves. So, what's well-being in an older adult? I'm not an older adult. It's really hard. And I hear people in the field of geriatrics talk about this all the time. People want to go into peds. They have kids, they can relate. People want to go into adult health because maybe they've had some problems or personal issues of themselves. And so it's easy to relate. It's easy to sort of stay engaged because you have something to relate that to. I often hear the struggle in geriatric nursing is that, we're not, I'm almost 40, so I'm pretty young yet. What experience do I have with older adults? So I've had to work extra hard to make sure that I really understand what some of the needs are of our aging population. And I'm in the right place to do that. I'm in a program that focuses on gerontology, but I still think that there's that practical piece, that applied piece that is so important. So I think that's how I've gotten where I am. But if you've never seen this, I encourage you to look at it. It's the World Health Report on Aging. It came out in 2015, and it talks about what healthy aging looks like in the voice of older adults internationally, and it's fabulous. And it really talks about well-being, where people are able to make their own decisions about their life and their care, where they stay functional and interacting with their environment, right? Those are some key things that are just incredibly important to people as they age, that they can still contribute and have a part of our society internationally. So I encourage you to take a peek at that. And I think that's how it's really colored some of the work that I've been able to be involved in. And you can see that these are just a few publications that my advisor and my chair have engaged me in here. I put on top one that I'm most proud of so far, and that's this licensed nurse and nursing assistant recognition of delirium in nursing home residents with dementia. How many of you knew, and don't be embarrassed, how many of you knew the difference between dementia and delirium? Were you taught this in school? Were you taught this in school? Because I didn't know it, I'll be very honest. I was like, oh, I know this, right? You don't. Because then we started getting into hypoactive, delirium superimposed on dementia, hyperactive, and just straight delirium. And I'm like, who would have known? But it's the detail that really counts. And so this project was very eye-opening for me. It brought in the nurses, growing nurses, which I love to do, and it also brought in, my taking care of older adults with cognitive impairments. It was the perfect match. So I really love this project and was very happy to be able to participate in it. And some more pre-doc work that I've done that I'm also very proud of. And so some other work that I've been able to do, I also was very lucky to fall into, and I think, clearly your advisors help you with this, but some work around testing a care planning process for resident choice. This was considered a person-centered care planning process. I'm like, well, we're nurses. We already do person-centered care, right? And care planning, that's what we do. Learned a lot about that, too. So I was able to, again, do a pilot focus group looking at risky choices of nursing home residents using this Rothschild care planning process. And really, again, what I was looking at is implementation of a care planning process in a nursing home where people who have dementia are often considered to be making risky choices, right? So we're taking away autonomy and right to decision making because you've crossed the threshold of a nursing home, and we know what's best for you. So my ethics hat came on, and my advocacy hat came on. I'm like, oh, wait a minute, something doesn't seem right here. I tested this and did a focus group and learned a lot about how we perceive risk, which then led me to say, okay, so how do we perceive risk? And then what do we do with that? And how does that guide our relationships with our clients? So that's currently where I'm at, and I think that this will really guide my dissertation. I think it will be an extension. Well, I know it will be an extension of this particular project. The message I want to send to you here with this pre-doc work is get involved. Like, this is what I've had to do to really get myself immersed in caring for older adults in this setting, because I don't know about you, but when I came out of nursing school, I said the last place I'm going to work is a nursing home. And that's where I'm doing my research. So I've never seen that. So in doing this, I think about, is anybody familiar with Dr. King's, well, she has two. She has the theory using King's conceptual system. Have you seen this? And then she also has a theory of goal attainment, which kind of butts up against this. Okay. I really like to think of things as systems, and King does. And she thinks about things as a social system, as an interpersonal system, and as a personal system. And really that they're all connected and they all relate. And I like this because it's given me a way to think about how we perceive risk and how that really influences the relationship between the nurse and the client. But overall, it also helps me think about conceptually, is this person-centered care? Is that what my dissertation topic really is in, or is it a nurse-client relationship? So it's helping me to bring clarity to my dissertation topic. So I wanted to share this with you. And I really wanted to focus on person-centered care, but I'm having problems. It's not defined, well defined at all, which I'll show you. So I had to take myself all the way back and say, what's a phenomena? And the phenomena is the grouping of concepts, right? And how we do that. And the phenomena here that I'm interested in is, what's happening in the personal systems, the interpersonal systems, and the social systems of a nursing home. So what's happening with the nursing home, what's happening with the communication in the nursing homes, and then what's happening with those individuals, the residents and the staff, and I mean staff in general, because most of the staff in nursing homes are not nurses. And have very, very little training, which, by the way, is a similarity in research. Many of us are thrown into research with no training, especially secretaries. I'm just saying, in my mind, it all fits. It's communicating it to everybody else that's the problem. So in terms of looking at the phenomena, I decided to call the phenomena person-centered care, and there was a debate on, is person-centered care concept? Is it phenomena? Is it just something that's nursing? So I just wanted to remind us, and King says, you know, a concept is the basic unit of the mind, just as a cell is the basic unit of the body. So I like that. And that concept structure the domain of knowledge in a discipline and a profession. So I'd like to think that the discipline is really long-term care. And person-centered care is how we're just sort of organizing it. So I like to argue that's a concept, and here's why. So I'm going to share with you a person-centered care concept mapping project. Who has ever done concept mapping? Are you familiar? Mm-hmm. I know you're. This is pretty cool stuff. I love that stuff.
Someone who's going to be doing it soon.
Yeah, I love it. And this again was an opportunity for my colleagues. So I work with Dr. Kalinowski, but I've also been very fortunate at my Kindergarten State to work with Dr. Van Heidsma. Dr. Van Heidsma is from the Polisher Research Institute, the Abramson Center for Jewish Life is where she started. She worked with Penn for a long time, and then recently came to the College of Nursing at Penn State, and we are so blessed to have her. She is a clinical psychologist, and she also is a quantitative researcher, and she's very clear. I'm a quantitative researcher. That's great. Maybe we can talk. And she gets clinical research, which is different. Like she started in the clinical world, which helps me speak academic world. She translates for me quite often. So I want to just acknowledge that I got pulled into this project because I became Kimberly's project coordinator, program administrator, in the program for person-centered living systems of care, which seems like a very natural fit for me. And she said, "Oh, Liza, do you want to work on this project?" And I said, "Of course I do. This just sounds awesome." So these are all of my co-authors, and she's given me the opportunity to lead a publication on this. So this is my journey to publication, which I was hoping to have submitted before I came here, but it sounds like we're going to be another week or so. But we hope to submit that very, very soon. And I see all the publications while I'm around here, by the way. Congratulations to those of you for getting those in. Those first ones are always your babies, aren't they? Like, I'll never forget them. So person-centered care, let's just start with it as a potential concept. And this is why I still call it a phenomenon to some degree, and why people argue that it is. So person-centered care with older adults, so we're just talking older adults, has, well over 15 definitions. I mean, these are some here in the systematic review. They're everywhere. And they're in, policy documents, like you're saying, they're in publications, they're everywhere. Organizations have their own definitions. They're used interchangeably: person-centered care, person-directed care, relationship-centered care. I will argue that there are differences in these. But this is very confusing for a doctoral student who's trying to do a dissertation. So tell me what the concept is and how do I measure person-centered care? Like, right, we're going concept, theory, empirical indicator. So I'm still stuck at the concept phase, which is a little bit stressful. So I was very delighted when the American Geriatric Society released a definition, because I thought, oh, perfect. Professional society has released a definition. This has to be it. It has to be a concept. And that's that the individual's values and preferences are elicited and once expressed guide all aspects of their healthcare, supporting their realistic health and life goals. Honestly, that hasn't helped me much. I don't know what empirical indicator to put on that one. But I do want to recognize that we're a step closer than older adults to finding what person-centered care means to our population, but it's still too broad. It's still not very operational, and it's still based on expert opinion. So Dr. Van Heidsma, being the quantitative researcher that she is, said, let's just look at this from a different perspective. Oh, I have one more. Sorry, I wanted to share this one. So you're mentioning earlier that it will be tied to reimbursement, and long-term care as of January 1, it is tied to reimbursement. Person-centered care, so this is a Centers for Medicaid and Medicare Services just released this update, final rule in long-term care, and the requirement is that nursing homes are practicing long-term care or they will not be reimbursed for the care, or person-centered care, or they will not be reimbursed for the care that they are providing. This is a problem because long-term care providers are just as perplexed as we are. They are on board. It's a culture change. People love it, but they still don't know how to implement it.
They all think they do it.
They think they do it, or either that or they just are completely hands-off, and I'm not touching this because I think it requires more staffing, it requires more resources, and they're just not, they're already strapped. I mean, long-term care does not have funding. This is a national health crisis. So for them, person-centered care means that to focus on the resident as the locus of control and support the resident in making their own choices and having control over their daily lives. This was closer for me. So to me, this is about decision-making. And I'll take you back to King for a moment. Decision-making is in that interpersonal phase, but really, thinking about personal, interpersonal organization, and it's really reflective of that. So they're all there. What I'm saying is all these concepts are there. So I'm still not sure how they fit together. So this inconsistent definitions of person-centered care and this lack of specificity to the long-term care environment, because taking care of someone at home, taking care of someone in a day center, adult day center, and taking care of someone in a nursing home are very different environments, and taking care of someone in a acute care, very, very different environments. So how do we get more precision so that we can guide clinical practice and research in this area? So what we decided to do is to find some conceptual clarity of person-centered care using a concept mapping technique, and we wanted to produce really a pictorial representation of what person-centered care looks like for the long-term care, and related ideas to that. So I'll share that with you. How we went about this, and so I will not profess to be an expert in multidimensional scaling. We hired a statistician for that, but how it works seems really cool. But basically, we use multidimensional scaling to produce these pictorial items of the related concepts. And then what we did is we also used a group rating of items. We did card sorting, and then we looked for distances, proximity and distances of the items, how they were sorted to suggest potential relationships. Okay, so that's sort of like an overview of what we anticipated doing here. So how did we even get the items to begin with? There was extensive literature search, and there's hundreds and hundreds, I'm not kidding you, hundreds and hundreds of tools that say they measure person-centered care. And so those were sifted through. I think that's before I came onto the project. But we had come down to 10 tools, final tools. And you can see here just the concepts, the domains as they were listed. We ended up with 44 person-centered care domains and 10 different tools. And these became the cards that were sorted, okay? So we did it at the domain level. So below the domains, typically when you have a survey, you have the items, domains, items. And so to do the sorting, we brought together a stakeholder advisory panel of 17 people. And we asked them to sort these cards in order of importance to them, to the concept of person-centered care and long-term care environment. And we did have representation of one older adult. We had one family caregiver, a professional caregiver. We had a couple administrators, long-term care administrators. Actually, I'm sorry that happened. Majority were gerontology researchers, which is obviously not atypical in the academic environment. We had a policymaker, a thought leader, and a surveyor. So that was our stakeholder advisory panel. In terms of the participants who we asked to sort the cards, the mean age of the sorter was 52 and a half. Most of them were female, not surprisingly. Most of them were Caucasian and had college degrees. And a lot of them felt that they had enough to make ends meet. So that tells you a little bit about, how they're perceiving person-centered care and the importance of it and rating these items. So I think we need some diversity there in the future. So as I mentioned, we use the multidimensional scaling as a quantitative analysis method to look at the sorted items and put them into clusters and groupings. And then we use the stress value to determine what the number of dimensions are. So I don't know if you guys are familiar with this, but basically, as I understand it, concepts can have a number of dimensions, several, more than 3, but the stress value will help you determine the right amount. So do I need to look further? Do I need to, stretch this out, or the things that I might be missing? That sounds somewhat okay. I'm looking over the more of the experts over here. And then we also did a qualitative analysis where we then took that information and we reviewed the groupings of the items to actually determine the final number of clusters. And then we we described the dimensions and clusters as we so we started labeling things. So this is just what the stress value looks like. And this, basically the stress value for the two-dimensional solution was 18%, and I understand you want it to be lower. So the lower it is, kind of the more accurate you are. Anyway, this showed us that we had to, I'm deferring to the statistician on this one. All I know to tell you about this is that 2 dimensions is what we came up with, and it's statistically validated.
Yeah. We're giggling because before you did that, I wrote here EFA in picture form, and it's coming up. So.
I love this process. Like, I wish I could just do this for my dissertation. This is so much fun. So each one of these I want to show you. These are where the items landed after everybody sorted them, and this is actually where the items landed on a 2-dimensional scale. Okay. And you can see all the items numbered there, and all those items go back to the domains that we saw sorted. Okay, so each one is, so I7 had its own domain. So what we did from here is we created a concept map, and we started labeling things. So each one, let me see if I can correct. So you can see here, there's kind of a picture. And the center point of that cluster is probably here. And what you're supposed to do in this multidimensional scaling, which is so cool, is you're really supposed to print this out and then trace it, the clusters, because it's based on distance, how close they are together, cut them out, and then they told us to take and balance it on a pen, and that's the center. And that's the item that is driving that particular concept. I love it. So I thought that was so super cool. So we should blow it up and print it out, but we didn't. We sort of eyeballed it. And created 6 different clusters here. And also, this went through that whole qualitative process. How do they group together? What kinds of items group together? And we stayed as close to the description of the domain, these sort of domains, as we possibly could to come up with our concept domain descriptors here. So this was quite interesting. Social environment, physical environment, interpersonal activities, extrapersonal activities. What we found so interesting is you could almost put this together like a puzzle. So you can see how, if you move these pieces, they sort of fit into a whole, and you can sort of see the 2-dimensional. And this really, with a group of academics, creates quite the conversation. Yeah. But we came up with these 2 domains, and so I just want to share these with you. Do I have a few minutes? Okay, I just want to make sure I'm not talked about myself too long. So the interpersonal activities and the extrapersonal, we call these dimensions. And so the northern domain, so those the clusters towards the top, the domains towards the top, were things that were more internal to the person. So getting back to that person. And they really described things that were more transcendent, spiritual in a way, and emotional. And the southern, at the bottom part, was really about the activities that were relevant to the environment, and that they were around practices, like evidence-based practices, nursing practices. So that tells you a lot. That was quite interesting. And then if you look east to west, on the more eastern side, we saw the physical environment around the person being really important. Aspects like the places that people live. So we said long-term care, and we described long-term care loosely. So that's just something for you to understand, and I probably should have told you that up front. So yes, most of it was nursing home, but if it touched, if the tool had touched the long-term care environment anywhere, then we considered it long-term care. So if they were discharged from the hospital and went from the hospital to rehab and long-term care, but then went home and that tool evaluated person-centered care, we included it. So that's why I think the places people live really kind of stood out, aspects of the places that they lived. And then on the other side, we looked at the social environment. So the physical, the social is more around how people are interacting with their environment. And you can hear me going back to King in my mind, right? So then we had the domain clusters, and the domain clusters represented the behaviors and attitudes. The first cluster was enacting humanistic values, and I love this. And this was the biggest cluster, and it was almost like right in the middle of this concept map. And it touched 3 of the 4 domains. And I say that if we did this with a bigger sample, it probably would have moved itself down. The items really address the psychological needs and goals of the person. Back to the individuals right in the middle. But it also spoke to how care partners support the person in fulfilling these goals. So that was quite interesting. And then the engagement facilitators. So now we're starting at the top, and we're going to the right. Okay, so we're going to go around and clockwise. So the items in this cluster really refer to the activities that engages the person's social connectedness. So really relating socially with other people. And I always put on the thought of, I'm thinking about a resident who's in a nursing home and, they're in the room, maybe with a roommate, most of them with roommates, but never comes out. I'm thinking, gosh, I couldn't imagine living that existence. No wonder they should up and die. And then coming down to living environment, items in this cluster really looked at the environment of the physical and social environment. So it had a little bit of both included in there. We found this very interesting, but really describing what's included in these environments to make them person-centered. And then supportive systems was more around workforce management and types of leadership. So our practice was really important there. And I would like to say that I think the lack of presence of nursing seems to really be, and that's where I think the leadership came out, because in long-term care, the registered nurse is the leader, just by nature, right? Just because you have to be. And then communication, huge component. And this was very clear that in this environment, in this context for person-centered care, it was the verbal and the nonverbal interactions. Having to have really good assessment skills, being able to have a bi-directional communication process, regardless of cognitive science. And then the final domain cluster is direct care worker values. So those items there were things that behaviors, attitudes, emotions of the care provider. And that really was an important cluster that was pulled out. So really, this concept mapping helped to contribute to our understandings of how the different elements of person-centered care are organized, the phenomena of person-centered care are organized in long-term care. It really gave us some clarity around how it's used in the long-term care environment, and created some really needed operational definitions so that we could start creating tools to measure it. And it also provided an opportunity for us to really think about how do we start testing the different relationships among those domain clusters, and how that might actually, how person-centered care itself might impact something like quality of life and those sorts of things. We went through practice. Obviously, we always know there's quality implications. It helps care providers sort of think about the main aspects that that are included in person-centered care delivery in that environment, and really kind of bringing it down to the context. Thinking about domains to target for resident satisfaction, and highlighting, when you're hiring staff, what kind of staff qualities do you want in a person? If you're really trying to harness person-centered care and make that what you're doing in your environment, what kinds of attitudes should those people have? And I think for educators, it's what kind of attitudes do we need to kind of help create? And then, things like building environments, and what things can we change to help these people? Researchers, we talked about developing hypotheses. The biggest thing that I think is most wonderful about this type of project is I think it really helps us, can really cause a harmonization of tools. There were hundreds of tools out there measuring person-centered care, and it's really hard to talk about measuring person-centered care if everybody's got a different tool. So bringing this together using quantitative methods to help define what is the most reliable and valid measure is really helpful to that science.
Speak a little to the promise.
Oh, a little bit. I will try to speak. So as I understand it, NIH promise recommendations is around just what we were talking about, trying to create a core set of tools that are used to measure different phenomena, really. I mean, it's really anything, but the whole idea is that the NIH is behind harmonizing or creating tools like this. The more we can do it, the better, so that we can all measure things in healthcare in a standardized way, so that we can cross-talk between different types of studies. And that becomes obviously really important for us in evidence-based practice, right? Because evidence-based practice, we still don't have enough evidence to guide nursing practice, but medicine as a whole. So if we can start working more interdisciplinary and using similar tools, that will be really helpful. And I think that's why I really like the American Geriatric Society too, because that's where we hope to publish this, by the way, is because it is a very interdisciplinary organization. So if they can support this type of research, that would be amazing. So limitations. So typically with concept mapping, you pull from the items, not from the domains. We pulled from the domains because the items were just, there were so many of them. And then we only used English measures, but we know that person-centered care is being studied in long-term care environment in in China, and we know in India it's being studied. So many different places. So this only obviously applies to English speaking. Things not items, stakeholder panel. I'd really like to see this again. Being someone who really believes in person-centered care, I believe that the person directs their own care. They're self-directed, and so I'd really like to see this repeated with folks. Older adults. Here are my conclusions. Any question? So thank you. I know that was a lot. I went over about 10 minutes. Sorry about that.
Absolutely great. Absolutely terrific.
Thank you very much. Do you have questions about the concept mapping or my journey?
My question is about the definition of terms and who you're going to use in terms of your sample. How does that work when you're looking at it through a global lens, when other countries treat the elderly so different? For example, a number of years ago, my sister was up in Iceland and I went up to visit her, and they had a geriatric daycare facility housed in the same structure with a kindergarten. Preschool. And I thought, wow, like that was just, I thought that was fabulous. But I'm sure like within different cultures, you're going to find, I'm just thinking globally is just so complex.
Well, I think that that's a really good point. And I think that understanding the limitations of this again, we looked at tools that, so first I think you need to be very clear in your descriptions of how you're looking at and what you're looking at. So if you use tools that are created for people here in the U.S., for example, in our culture, and how we take care of older adults, that's obviously going to tell you something way different than using a tool from Europe. Although there are European tools in here, I think it depends. We work a lot with neuroscientists and other scientists, geroscientists, in person-centered care in Australia and in the UK, and we even find them being more progressive than we are in here. So we actually like that perspective in here. And in Germany, we have a German counterpart we work with a lot co-op on this. So we just try to include them in we use the still care panel, but the scientists who help write this paper and look at the concepts, we included their perspectives in creating the conceptual definitions. Does that?
Yes,
that's maybe one way to do that.
Job in itself.
I know.
Isn't that awesome?
Yeah. I know. It's really cool work, and I'm just so blessed to be part of it. It's great.
Regarding the nursing home, in the United States, you have the long-term and the extended care facility. I'm not sure what configuration you have abroad, but what population did you look at? The long-term?
So we looked at long-term. We looked at extended term. We looked at anyone who would be grouped in that umbrella. So it could be someone, it could have been someone who had, like I said, were going into primary care clinics but had touched long-term care. The tool itself said, not the person, but the tool said, this can be used in long-term care environments. So it's how they self-defined. So we did have that was hard to do just extended care because there aren't. So it's funny. There's hundreds of tools, but there aren't enough for that particular environment. So that's kind of interesting too in of itself, right? Does that answer your question? Okay, so extended care was included in that.
So your definition of long-term included that they have to be in an institution, because if you were doing home care, there is a part of home care that's long-term care. Do you see that working? Do you see perhaps maybe
using this concept map in that environment? So I think it could start that discussion, and I think it could work in that environment, but it has to be, I think we'd have to do some more sort of testing.
So your definition of long-term care was?
So long-term care was any care, any environment outside of acute care, or acute, or oh gosh, I'm trying to think of the other word. I'm sorry, I just lost it. So it just can't be hospitalized. So no acute care. And I was just trying to think of the other word that, sorry, it'll come to me. So anything that's not acute care and that required, like follow-up, really. So it wasn't, they had to touch long-term.
An institution.
Well, an institution in that
they're
they had
aging in place in their home.
Right.
And they're being cared for, and
if they went to their primary care, then we would have included it.
Right. They have a primary care. There are nurses.
Right.
Right. So I could probably see that.
It just couldn't be acute care, and I'm thinking the word for acute care rehab. What is it? It's
not a skill.
You'd like no, not a skill. That would have been included. Subacute. Subacute care. Thank you. So it's and then that was a little bit. I think some of us, the researchers on the team were like, oh, you really did this, but we determined that if it wasn't acute care focused, if it said that it measured anything in long-term care, then we would include it.
I think two of those tools can be used in home care that you showed originally, because I did home care for a fair amount of years. And you were testing the tools for person-centered care. You were not focusing on the population, you were focusing on the tools and the domains within the tools.
Domains within the tools, but they were related to that population because we wanted to narrow conceptually. And we actually have the tools listed out for different, so we have the tools listed out for acute care, and we have them pulled out so that we could look at them, like to repeat it. The tools are divided into like 4 or 5, and I couldn't tell you them all off my head, but 4 or 5 different environmental contexts that we could repeat this study.
How many sessions you say those stakeholders of 17 of them sit together? Like how long is the session for them to run?
So actually, they didn't sit together at all. This was done, it was a card sort, and actually it was done online. So it was a program, an online program that did card sorting. That's card sorting. Yeah, it was an online program that we used to do that.
And so they do it at their own convenience.
At their own convenience, they could take as long as they want.
The time around 1 hour, 2 hours.
No, they didn't take that long. No. I mean, there was an average time. It's cool. Did I put it in here? Very cool. I did not put it in here. No one took over.
Is there any chance in the
That's in the
future
publication. I could look it up.
you may be doing it in a different, in terms of stakeholder change, diversify, or in a different group? So, and compared to outside.
Somebody ought to.
I think the idea is
I am shameless.
to replicate
In a different population.
Well, I don't think it's terribly difficult. I mean, it's time consuming, and so we were lucky that Dr. Van Heidsma actually funded the program. We had the statistical program and the time to look up the tools and to sort. And then we're all scientists, so we are all scientists, so we all were happy to donate our time to sort of do the analysis. So that's really the cost behind it, and that was donated. From her program of person-centered living
And
systemic
you
care.
use a specific software to map it out, or just?
Yeah, she did use, statistical software, yes.
The stats, but not the diagrams.
The diagrams, well, the diagrams are part of the statistical program.
It's just a principal components analysis.
Yeah.
You do with any stats, you can do with Excel.
Yeah.
No, one of the cool things that I did in the index card sort day was use a statistical an analysis package called Expert Choice. Expert Choice does it's a multidimensional scaling sort of, but the mathematics behind it is analytic hierarchy process, and it does pictures when it's done, but not squares and arrows. And it allows group sorts as well.
Yes,
So.
and the program we use, just so you know, is called Optimal Sort, and it's a web-based program.
Cool.
Yeah,
Very cool.
It's a web-based program.
But the mathematicians will argue that multidimensional scaling is conceptually different than analytic hierarchy process as a mathematical set of principles behind it. And you got to get through those weeds so that when you're starting with that kind of scientific pursuit, you got to know that the mathematicians are busy doing other sorts of stuff. But it's what makes interdisciplinary work so exciting. And so I'll bring that to my last question for you so we can wrap this up somewhat, is the fun it is to work with people in other disciplines. Did you have fun?
Yes, I always have fun with that. And I think different disciplines, we had 2 clinical psychologists, like I said, and most of them were nurse researchers, and some social scientists. But I think also working with people in other countries, other nurses in other countries, was enlightening as well. And that's always, and I think that's what my draws to ICRN as well, is, we do things alike, so why not, or very similarly, why not draw on each other's knowledge? We do them alike, but we do them differently, I guess, is how I want to, it probably doesn't make any sense, but I think that just adds richness. So if you're defining something, why recreate the wheel? Why not build off of something that we already have? And I think something like this lends to conceptual clarity on so many levels. One, because it's not just expert opinion, it has some empirical. I mean, obviously those concepts were important enough to be on someone's survey to begin with. It had some reliability and validity to the surveys, which we didn't, I don't think I put all those in the publication, but so it had some statistics for each of the surveys. But then on top of that, you've now taken those and said, okay, these are what people are willing to measure about person-centered care, so these concepts must be important. Now let's group them and say, okay, now what? Now let's think of that as a bigger, larger phenomenon.
That is really great. What I want to do is give people outside, give you a couple of seconds, that you have a chance to ask questions as well, if you'd like to, before we kind of let people have lunch. Anybody from the outside, I'll see whether or not anybody's there. Wake up and unmute yourself. If you have any interest at all, please chime in.
Dr. Feith, actually Maureen had sent me a message saying that she does not have a mic.
Okay.
So,
terrific. Well, she can type in a
yeah,
question.
if she wants to type in.
Yeah, absolutely, if she wants to. Maureen, if you can hear me, just type your question quickly to Fran, and she'll ask it. But let me give Giselle, if she would like to say something.
No, that was just a really great presentation. I was really happy to, partake in this, and thank you so much for sharing your journey and, your experience thus far. It's really enlightening, for sure.
Thank you for listening.
Thank you. And then what I'll do is give Fran a little bit of time, whether Maureen can type fast enough, and entertain any other kinds of questions or comments. One of the things I think that, thank heavens, Liza brought up are those, aside from the research, there's so many personal parts of this that I will guess you all felt a sense of, I know how that is, I've had that experience, I've had a loved one, I've felt that kind of conflict. I have one pre-doc who is hoping to look at that. We started with pain, we're probably going to do falls in a secondary large database analysis, but that elder patients in our care have their own personal sense of what they want. And Jen's been at, I'm talking for you. You say it. You say it. You say it.
This all stems from Martha. Martha's my grandmother. She's 91. Yep. She lives alone. She does all this stuff. I just want our patients. I think about what that would be like. I'm in acute care. What that would be like. They come in and we do all this stuff to them and talk to them and at them. And how do we get over that risk aversion that we have to let them, while they're there, we want to give them something more than just Tylenol because they're having pain, but we're afraid to, and we don't want to let them get up because we're afraid they're going to fall. And all these things are just they're not good.
They're not good. I think we take a very paternalistic perspective too early with our loved ones. And we do that, I think, out of love. We want to protect them.
Sure.
But the reality is that they've lived a lot longer than we have. They've been around this block. And so I think the first thing we do is owe them respect. And the respect is that they run their own lives. And we're just there to help them. Staying in home is, I passionately believe that that's where people belong. And their environment is so important to them, especially when they become demented, right? Because that's what they're familiar with. And so as soon as we take them out and put them in a nursing home, we've created problems right there. So that would be great if you can keep that passion.
She's keeping it.
Keep that passion.
Emma?
Interesting, I just came across something the other day that, the whole focus on fall prevention and how it has really impacted the elderly. We actually restrict them more.
We do.
Of course, when they, this is certainly like, I know mostly from acute care, but really it's become much more restrictive because of the punitive nature. Once you have a fall, then, there's all these ramifications for the unit, and of course the unit with the least fall, most days without any fall, this whole system that we put in place has serious
unintended consequences.
Yes,
Well, my policy folks are going to have to
now
learn how
we
to
just
say.
are going to further restrict because we want to be the unit that has the, goes the most days without any falls, right?
Where is it all right to restrict? And are we doing more damage? So this is why I get into this world of perceptions of risk, because when are we doing more damage?
Right.
And rather than honoring and
But,
respecting.
the falls are negative, so everybody sees the fall as the negative, so preventing it then translates in being positive. And the consequences are we limiting mobility for the elderly.
We are limiting mobility. There's actually a
no
study in
question.
long-term care that the doctor, Dr. Kalinowski, Dr. Van Heidsma, and Dr. Resnick are doing in a long-term care. It's an implementation study around, working with behavioral and psychological symptoms of dementia toolkit to give providers to how they can manage these types of symptoms so that they can promote autonomy and self-decisions and those things, and not restrict, things like limitations around mobility. And they use what they call function-focused care to do that.
Function-focused care. That doesn't add to our other discussion with this international symposium.
It's a very hot topic.
Before I go to Dublin.
Yeah. Preference-based living. .org is the website that we're putting together. It has the tools very similar to this project. Kimberly had done one before this that she did with preferences, which is her real area of interest. And preference-based care, or preference-based living.org, I think it is, has her preferences for everyday living inventory that was created starting from a concept map like this. And now she's taking that out into many different settings, but it's been validated and tested in long-term care. And it's about asking people what they prefer, what's your preference, and how satisfied are you with that preference. And so this is a way that we can provide person-centered care by asking. We fast.
That's great. I think I'll close with that. I haven't gotten any other questions. Please join me in thanking Liza. And if you have